Well, thank you everybody for joining this evening on the Respiratory Therapy Student Club, School of Healthcare Respiratory Therapy. Tonight is June 10th. My name is Sean Matheson and I'll be helping host the meeting tonight. I don't see that any students yet have joined us, and that's just fine if you are listening to this by recording. Our main goal here is we would like to get your participation as much as possible. So if you can join in future months, we greatly appreciate it. Your feedback, your input really helps inform the content and drive what we do. So I will transition here to our agenda slide and introduce, well, no introduction really needed, but Daniel Williams has an announcement for us on PPE.
Hello, everyone. I hope you all are doing well. Just to write quickly, a couple of things that have come in this week are some comments or concerns about PPE as there's, it's been publicly announced through media that there's a shortage with PPE and so forth. But wanted to kind of get a filler out there for those of you that are able to go back to the clinical site. Are there any issues with PPE? Are any of the sites requesting that you provide your own PPE? If there are, you can feel free to give me or send me an email at daniel.williams@independence.edu and just make us aware that it's not certain that the university will be able to provide PPE, but if there's we just want to see what the need is out there for that, to see if that's something we should address in the future. So if you guys have any issues concerning hospitals wanting you to provide your own PPE, please make sure that you bring that to my attention. You can send me an email at the email address provided there. Thank you.
All right, thank you, Daniel. Appreciate that. And I would like to just remind everybody about the Facebook IURT group page. You can find that there on Facebook under Independence University School of Healthcare Respiratory Therapy. And you'll note there that we are now 120 plus members. This Facebook page, you'll recall, came about from your feedback as students. I believe that was 2 or 3 meetings ago. The goal there is you can message each other. I know really a lot of people don't message each other in Canvas, even though that feature is there. So it's a nice forum where you can message each other, share ideas, and really connect with each other as best possible. I also want to just make a quick announcement that next meeting we really would like to get into student club officers. We've had some good attendance, probably 4 to 6 students the last few meetings. Unfortunately, nobody's able to join tonight. I will be watching the participant window as Daryl is presenting his material, and we'll welcome you in. We will hear the chime and welcome you in. So do please attend. If we can get good representation there, then I think we can do nominations. And I think it looks great for your resume. If you've been a president, vice president, etc., for anything to do with a leadership position. Also regarding next meeting, we do have a prior request from you as students to talk about career paths. So we've got a nice specific agenda that we have come up with based on our experience and based on your feedback. So know that next meeting, that will be our topic. I also want to invite you for future topics to email me. I'm at sean.matheson@independence.edu, MATHESON. Or you could shoot an email to Daryl. I know that you have a lot of interactions with him regarding the test. So your request for topics really drives this, and in fact is what is the topic of tonight. Per your request as students to talk about assessment skills, Daryl did a great job last meeting going through a good number of slides, and then tonight we will conclude with assessment skills. So Daryl, I'll stop screen sharing and turn the time to you.
All right, thank you very much. I'd like to first just remind everyone that this program has full accreditation from COARC, the programmatic accreditor. That took a lot of effort from the faculty, working hard with students and making needed improvements. But we do, in fact, have full accreditation from COARC at this time. I think that most of you probably received a notification at some at some time about probation, and that was true, but no longer. This is a fully accredited program, so you can have peace of mind in that regard. The real world case study I would like to share has kept me very busy for about 3 weeks now. And let me just explain. This is how COVID, coronavirus, actually spreads. Near my home is a meat processing plant in Guyman, Oklahoma. It's the panhandle of Oklahoma. I think there are about 700 employees there, and to date, about 240 of them have tested positive for COVID. How could that happen? Well, the nature of a meat processing plant is that workers literally stand side by side in order to complete their duties. In order to do their work, they have to be side by side. There's no prospect of 6-foot social distancing in a meat processing plant. It simply wouldn't work. So these are healthy young employees by and large, working at the meat processing plant. But what they did was a very natural thing. They went home. They finished their work and they went home. In this part of the world, the extended family is culturally a very normal thing. And in those homes are children, of course, the workers, parents, and grandparents all living in the same home, or perhaps mobile home and sometimes. So what happened is that now we have 890 cases of COVID in a relatively rural area where the hospitals have no prospect of keeping up with that. It has overflowed into my regional medical center, which is located in Woodward, Oklahoma, and even overflowed from there to our flagship facilities in Oklahoma City. So all of us, and I do mean all of my students who are studying here on ground, have now been hired. The juniors, the seniors, the faculty have all been hired and essentially, how shall I say this, recruited, volunteered, or voluntold. Somebody said the best term is voluntold, that we need to come help. And how can you say no? So that's what we are doing at this time. And actually, we've seen a small decline in admissions to the hospital at this point, which is hopeful because we are pretty much exhausted at this point. But nonetheless, this is how a virus like COVID, coronavirus, spreads. It takes time and it takes close proximity among individuals for the spread of this virus. I think that the initial concerns about people picking up this virus from sitting close to someone in a restaurant, probably just not very realistic, but we are seeing where it happens. It also happens in long-term care facilities where individuals are there for a long period of time with a caregiver who perhaps has brought the infection, unfortunately, to the facility. So, wow, I did not really think that we would experience COVID to any significant extent. We're quite rural here in Oklahoma. We do not have close proximity to each other on a day-to-day basis, but in that meat processing plant, we certainly did. And that is where we're at this point. So I got to experience it firsthand. Yes, please go ahead.
May I ask you a question on that?
Yes.
It will be by purchasing the meat, cooking the meat, will that kill the virus?
Indeed. There's no concern at all about the product. There's been, very substantial testing of the product itself. I'm sure people will be concerned about that. I bet you have noticed, certainly we have here, that the price of meat products is absolutely through the roof, and that's because production is way down. We're simply not able to produce anything close to the quantity that is demanded by the public. But as far as the safety of the product, that's not the issue at all. Safety of workers, definitely an issue, and safety of their families, a bigger issue. The individual workers, I think this might be interesting for you and for those listening, the individual workers experience something like flu. They say, well, yes, this might be a little worse than the flu that I had last year. But they're over it within a week, 2 weeks at the most. The problem is they took the infection home to their grandparents. Maybe a 30-year-old worker with 70-year-old grandparents, and the grandparents are our patients. They have absolutely filled up the hospitals here, and we do not have the capacity, not nearly enough respiratory therapists, not nearly enough nurses to take care of them. So we're just doing the best that we can. And honestly, happy to see a decline as hope that this will pass, but it's been something that I've never experienced in a 30-plus year career.
That is amazing. Well, appreciate you sharing that real world case study. Daryl, I will stop sharing screen for your share screen and portion on assessment skills. And I'll continue to monitor the participant window if anybody joins.
Thank you very much. Let's do a share screen, share computer sound, and optimize the video. And then we'll share and come over here to assessment of respiratory disease, where last time we made it through 50 slides, the first 50 of a little more than 100. So let's go from there. We went through the basics, and now we'll talk about some specific findings, common abnormalities that we're looking for. We talked about, observation, palpation, percussion, auscultation, the basic chest physical exam. My observation, I think maybe Daniel would share this, is that doctors don't do this examination as thoroughly as they used to, perhaps not as thoroughly as they should. They're just so busy and very focused on high technology approaches. So someone needs to do this exam. What are we looking for? Inspection, which I prefer to call observation, but it's the same thing. Pursed lip breathing. If the patient is exhibiting pursed lip breathing, exhaling through pursed lips, then they are trying to get the air out. They're trying to prolong the expiration to get the air out so they have time and room, frankly, to get the air in for the next breath. The tripod position is where the patient is lying or leaning. Leaning is a better word. Leaning on something. Maybe the bedside table is an example. Maybe a bed rail. I'm sure that Daniel has seen this. But they can't lie flat down. They simply cannot, because they're using the muscles of the chest and the shoulders and even the neck to breathe. Accessory muscle use, the intercostal retractions, we actually see the muscles between the ribs contracting to help breathe. Splinting means protecting a certain area of the chest, perhaps to facilitate breathing or coughing. Increased AP diameter, this is a board exam point, so please make sure you get this terminology. What we call the barrel chest is on the exam called increased AP diameter. So watch for that to indicate respiratory distress. Tachypnea is simply breathing fast, and many of our patients do that. And then Kussmaul's respiration, that is the diabetic ketoacidosis type of breathing that we see. It's rapid, it's deep, and it's very classic of diabetes that is out of control. Those are some key inspection points. Other things we look for are cyanosis, that's blueness of the patient's skin. But I must tell you that cyanosis is a very late indicator. The patient has to be really, really in distress before they turn blue. It takes 5 grams per deciliter of desaturated hemoglobin for the patient to appear blue, and they have to be very sick before that happens. Clubbing of the fingers indicates long-term hypoxia, long-term low oxygen levels that actually damage the tissue under the fingers. So we watch for that. We call it ET, call home, because the patient's fingers actually start to resemble ET from the movie. I'm sure most everyone has seen that. Peripheral edema, swelling of the ankles in particular, distended neck veins, cough, of course. Sputum, we're very interested in the amount, the color, and any odor to the sputum. The odor could indicate bronchiectasis, cystic fibrosis, perhaps chronic, long-standing infection. The Pseudomonas organism is particularly noted for that. And then abdominal paradox, which means that the chest and the abdomen do not move in synchrony. They have gotten out of synchrony. They are become paradoxical. Moving ahead. Palpation, we look, of course, at the position of the trachea, and the trachea should be exactly midline. If the trachea is shifted to one side or the other, we're very interested in that. Pneumothorax and pleural effusion push the trachea to the opposite side. Atelectasis pulls the trachea to the same side. And then fremitus is the vibration from the patient's speaking. We have the patient say 99. I don't know why we say 99 instead of 88 or 70. We say 99, and we feel the vibration. If there's an area of increased fremitus, that means consolidation, which usually is pneumonia. Altered chest movement, a delay, a lag in the chest movement is of interest and could very well be a condition of pneumonia or pleural effusion. And then percussion, we percuss the patient's chest, we thump on it, and we might hear hyperresonance, which means extra air in the chest, or we might hear dullness, which could be pneumonia or pleural effusion. So those are some of the common assessment abnormalities. They're very significant, and the interesting thing about this is that physical exam for generations of healthcare professionals was all that we had. So, the fact that we now have CT scan and MRI and PET scan, those are all wonderful tools, but the physical examination, the assessment of respiratory distress continues to be important. And I see respiratory therapists as the keepers of that art. I see us as the keepers of this art. Fine crackles indicate CHF, congestive heart failure, or perhaps pulmonary edema. Coarse crackles mean pneumonia. Rhonchi indicate sounds caused by secretions. There's a famous question on this TMC exam. I would say 100 students have now asked me about this question. Here's the question. Your patient has adventitious lung sounds which clear with coughing. They go away with coughing. Those have to be rhonchi, because only rhonchi are caused by secretions and will actually go away when the patient coughs and moves those secretions. Wheezes, we talk about sibilant and sonorous. Some people say sonorous. I'll accept that. Sibilant and sonorous wheezing. Sibilant is a bronchospasm. It's the classic wheezing of asthma. Sonorous wheezing are the same exact thing as rhonchi. A big part of this test, as I mentioned last month, is the terminology. So sonorous wheezing or sonorous wheezing is the same thing as rhonchi. Stridor is the upper airway sound that is classic of croup. It is a barking sound. Let me explain barking as in a seal barking. If you've ever had the opportunity to hear a seal bark, that's the exact sound of stridor. Not so much a dog barking. Absent breath sounds, well, absent breath sounds could be pneumothorax or could be the endotracheal tube too far down so that it does not ventilate both lungs. A pleural friction rub is pleurisy. Whispered pectoriloquy is where the patient whispers, but we hear the sound as though they are speaking out loud. And that is the transmission of consolidation. We say that the consolidation, the pneumonia, transmits sound better than air, and consequently we hear a stronger sound. Bronchophony is a very similar thing where we hear the sound transmitted from the bronchi to the chest wall, and egophony is the E to A change. The patient says E, but we hear A, or more specifically, we hear ah, ah, ah. And this is the sound first recognized by the ancient Greek physicians as the bleating of a goat. Egophony is the sound of the goat on the patient's chest. I love it that that has persisted through these thousands of years. Egophony, the E to A change. In-depth common clinical manifestations. This will go to a higher level here. but you can certainly understand this based upon your coursework and your training. Tidal volume should be about 500 milliliters for many of our patients, about 7 to 9 milliliters per kilogram. And if you are going to pick one particular number for tidal volume, go with 8 milliliters per kilogram. The NBRC has told us that is their number. Ventilatory rate, about 15 with a range of 12 to 18, and an inspiratory to expiratory ratio of 1 to 2. The patient needs twice as long to exhale as they spend inhaling, twice as long to exhale. Now, if your emphysema patient exhales in 3 seconds, that's good. 4 seconds is more common, and we do see patients that exhale in 5 seconds, which means that almost all of their breathing time is trying to get the air out. So 1 to 2 is normal, but we see, wide variation in that particularly in emphysema. Common pathologic mechanisms: lung compliance, airway resistance, peripheral chemoreceptors, and central chemoreceptors. All of this is showing up on the board exams, so let's take a closer look. The Herring-Brewer reflex is a stretch reflex. Nature gave us this reflex to help us understand that our lungs need to stay inflated. And if they don't, we get a signal through the central nervous system saying, wow, you need to take a deeper breath. You need to inflate your lungs. Deflation reflex kicks in when the lungs have been deflated for too long, as in atelectasis would be a classic example of that. The irritant reflex is what causes all of us to cough, but the irritant reflex that won't go away is very interesting and important. Right now, our patients with COVID have this cough that simply won't cease. We try all the normal things that we use to help them with that cough that is just wearing them out, and it's not helping. So that is what you've heard about in the media as the storm. The storm simply won't let them rest from coughing, and it also won't let them diffuse oxygen the way they need to. J receptors are juxtapulmonary capillary receptors, which also kick in when the lungs are not staying inflated. Some of us think that has to do with the amount of movement with each breath. Reflexes from the aortic and carotid sinus baroreceptors also kick in. They're looking at blood pressure and how to regulate blood pressure, and then pain, anxiety, and fever. All these are important mechanisms. I often say to my students in class, I say, aren't you glad that you don't have to keep track of all this yourself? Aren't you glad that nature does this for us? Because, how would we possibly keep track of all that? That might be a duplicate slide. Lung compliance and its effect on ventilation is very interesting. Compliance, you must know for board exams, is the change in volume divided by the change in pressure. And for example, 0.2 liters and 2 centimeters of water pressure gives us a lung compliance of about 0.1 liters per centimeter of water. And that would be considered the normal for your board exam. So if they give you someone with a 0.05 lung compliance, then those are stiff lungs. If they give you someone with a 0.2 liters per centimeter of water, then those would be overly distensible lungs that might be emphysema with increased lung compliance. Yeah. So this shows you the curve, the normal volume pressure curve for how the lungs expand. Basically, there are a wide range of different lung compliance measurements for different conditions, but we have stiff lungs in restriction, and we have overly compliant lungs in obstruction, particularly in emphysema. That would be a key point to get from there. And here you see the increased compliance line. Increased compliance would be emphysema, the normal compliance line, and then the decreased compliance line, which perhaps would be pulmonary fibrosis as one example. Right, moving ahead. Increased airway resistance. And decreased lung compliance, this is how we move, and it has to do with ventilatory frequency. If the patient is breathing fast but shallow, that would be a restrictive problem. They can breathe rapidly, but they can't expand their lungs very well. If they're breathing slowly but more deeply, that's an obstructive problem, with COPD, emphysema, being the classic example of that. You might have an example of that on your TMC exam. Airway resistance, which we just call RAW for efficiency, airway resistance, or RAW, is defined as the pressure difference between the mouth and the alveoli divided by the flow rate. And whoever created this slide did not realize there needs to be a dot above that V. Just V is volume, but V with a dot over it is flow rate. So for your test, be sure you know that airway resistance is change in pressure divided by flow rate. That's a V with a dot. For an example, change in pressure divided, here we have the dot over the V. So they caught it on the next slide. But 12 centimeters of water divided by 6 liters per second of flow gives you 2 centimeters of water per liter per second, which might be realistic for some of our patients. When I took this exam, I was given a patient with an airway resistance of 7 centimeters of water per liter per second. So that tells you that that patient has significantly increased airway resistance. Perhaps asthma, I would say that would be the most common example. There could be others. Airway resistance in the tracheobronchial tree is normally about 1 to 2 centimeters of water per liter per second. So you just need to know that fact so that you can analyze the data which might be given for a particular patient. Peripheral chemoreceptors, these are the oxygen-sensitive cells that react to a reduction in oxygen. When the oxygen level goes down, perhaps because of disease or perhaps because of just going to high altitude. I have a special interest myself in high altitude physiology. I find it fascinating. So let's just say that you're in Oklahoma City, my hometown, on a particular day where we're just about sea level. We're just about sea level. And you decide that same day to go to Breckenridge, Colorado, which will be perhaps 14,000 feet above sea level. Well, your chemoreceptors are going to say, what the heck just happened? Because they're going to notice there's a lot less oxygen up there. So they will kick in and cause you to ventilate more. They'll also cause your bone marrow. I think this is absolutely fascinating. They actually cause your bone marrow to start producing more hemoglobin and more red blood cells to try to help you deal with the low oxygen level up there. Absolutely fascinating, and a miracle of nature, I think, that our bodies can react. And it happens literally within hours and continues for days to help us adjust to the environment. This is where they're located. These oxygen chemosensitive cells are located at the bifurcation of the internal and external carotid arteries. You see the common carotid artery there. The baroreceptors are very close, and that's because these things are all interrelated. All of this actually is interrelated, and only nature can keep track of that. There are also sensitive cells in the aorta as blood comes out of the heart, and they cause, similar responses as they measure oxygen and pressure. So hypoxemia is one of the things that we focus on, of course, as respiratory therapists. It's low oxygen in the blood. Hypo is low, oxygen, emia, the blood. Decreased ventilation perfusion ratio is a factor, meaning not enough ventilation to match the perfusion. Pulmonary shunting is a factor, and venous admixture. Those are really the three main causes of hypoxemia. You can expect to be tested on these as you take your TMC exam. Here's alveolar ventilation, 4 liters per minute, and perfusion, 5 liters per minute. That's very much what nature intended. The ratio of ventilation to perfusion is about 0.8. And by the way, that is a question which has appeared on the TFC exam several times, is what is the normal ventilation perfusion ratio? And it's going to be about 0.8. Decreased VQ ratio, ventilation perfusion ratio. By the way, many students ask, why on earth would Q be perfusion? Well, I decided to study that and find out myself. The French physiologists who decided on Q were calling it the quantity of blood flow. So VQ ratio is ventilation compared to the quantity of blood flow. Most lung problems like asthma, emphysema have a low VQ ratio. A high VQ ratio would be pulmonary embolism. And what happens there is that ventilation continues, but perfusion drops dramatically because of a blood clot that will not allow the blood to flow. So that will be a high VQ ratio. That is a classic exam question. Here we look at the anatomic and alveolar and physiologic dead space. We all have anatomic dead space. That's just the tubes. It's the tubes that carry air down to the alveoli. Alveolar dead space, when an alveolus is ventilated but not perfused, blood clot comes to mind. That would be alveolar dead space. And physiologic is the combination of the two. You add up anatomic and alveolar and you get physiologic dead space. Shunting. Shunting, we have anatomic shunts that are completely normal, but we also have anatomic shunts that happen because of a developmental defect, perhaps, or a disorder of some kind. Congenital heart disease comes to mind. Let's say you have a ventricular septal defect, a hole in the ventricle, the septum, because between the ventricles. That would be an example. Intrapulmonary fistula, pulmonary vascular tumors, which are relatively rare, but you could encounter them. And then capillary shunts like atelectasis, alveolar fluid accumulation, and alveolar consolidation. So those are types of shunt. And then those are actually demonstrated here. You see the anatomic shunt, the capillary shunts, relative shunt defects. Anytime that you have perfusion without ventilation, you're dealing with a shunt of some kind. We all normally have a 5% shunt. There's no way to have perfect matching of ventilation and perfusion. So we all have about 5% shunt, but pay attention to this next comment. It will get you a couple questions right on the exam. For every 100 millimeters of mercury, every 100 millimeters of mercury of AA gradient, meaning the difference between alveolar and arterial, you pick up 5% additional shunt. Let me say that again. For every 100 millimeters of mercury of AA gradient, meaning the difference between alveolar and arterial, you pick up another 5% shunt. That will help you so much on the test because it's too hard to actually do the shunt calculation. Relative shunt, hypoventilation, drug overdose, classic example. Decreased ventilation perfusion ratio like emphysema. Increased alveolar capillary membrane, probably, I would say actually, pulmonary fibrosis is the best example. The other ones they provided here are valid, but we see more pulmonary fibrosis. So hypoventilation, decreased ventilation perfusion ratio, and increased alveolar capillary membrane. And then those are shown graphically here, the same kinds of things. Shunting, normal alveolar capillary unit, anatomic shunt, capillary shunts, and then types of relative or shunt-like effects. Venous admixture, this is where you have mixing of shunted blood with reoxygenated blood. One example would be a patent ductus arteriosus, which we see in many premature infants. I would say that should be your classic example of that. Mixing of oxygenated blood with deoxygenated blood, and we need to correct that situation quickly in most patients. So this is how it works. You have venous blood mixing with oxygenated blood, and it should come out, normally about 80 to 100 millimeters of mercury, but it comes out 40. So this is a very significant phenomenon. Typically, what's needed there is not just oxygen, but also PEEP, a positive end expiratory pressure. Factors that stimulate the chemoreceptors: decreased pH, which is acidosis. I love it that they put increased hydrogen ion concentration here. That is exactly right. We normally don't hear it expressed that way, but that's the physiologist presenting here. Decreased pH, which is increased hydrogen ions. Hypoperfusion, poor perfusion. Increased temperature. Nicotine in particular is the chemical that causes this and causes so many other problems for our patients, and the direct effect of the carbon dioxide itself. Those are all things that your body senses and makes adjustments to. Here are the diseases. I wish I could go over this entire slide, but there's just not time to do this. But take a look at this, and I'll be happy to send you this PowerPoint to show you which diseases cause a relative shunt-like effect and which cause a capillary shunt. This is the actual physiologic loop that manages this process for us, although we're not aware that this is happening, but it's happening every moment that we're alive. A low PaO2, a low oxygen level in the blood, stimulates the respiratory components of the medulla to increase alveolar ventilation. Yeah. If we see a patient who is hyperventilating, I'd really like you to focus on this for a minute. If you see a patient in the ER who is hyperventilating, the first thing you should consider is their blood oxygen level low? That may be what's causing them to hyperventilate. Central chemoreceptors, let's go there next. These are the central chemoreceptors. They happen in the apneustic center, the dorsal respiratory group, central chemoreceptors, pneumotaxic centers, and the ventral respiratory group. You do not need that level of detail for your board exams, I'm happy to tell you. But you do need to know that there are these chemoreceptors. Decreased ventilation, let's say in drug overdose. Let's use that example because it's classic. Drug overdose causes decreased ventilation, increased carbon dioxide, increased CO2 in the cerebrospinal fluid. That causes an increased hydrogen ion concentration, a decreased pH, and stimulates the chemoreceptors to cause us to increase ventilatory rate and also, I would say, ventilatory depth. So that's the loop. That's the physiologic loop that nature uses to keep this in order. The pulmonary reflexes include deflation, irritant, juxtapulmonary reflexes from the sinus baroreceptors, pain, anxiety, and fever, which I think we actually mentioned here a little while ago. The accessory muscles, we now move to the muscles of breathing. I think this is fascinating. Nature intends us to breathe with our diaphragm, correct? Nature intends us to breathe with our diaphragm, but our patients often breathe with many other muscles because their diaphragm is not functioning correctly. The emphysema patient, for example, has a very flat diaphragm, and that flat diaphragm does not work very well. So they breathe with the scalene, sternocleidomastoid, pectoralis, and scalene muscles, and we're going to actually show you those graphically. Those are the scalene muscles attaching from the vertebrae of the neck to the clavicle. Often you can see your patient breathing with these strap muscles in the neck. I'm sure you've probably heard that term at the hospital by now, the strap muscles in the neck, and they are actually elevating their chest with those muscles. Is that a good way to breathe? No, it's not, but it's what they have to work with. Here's a side look at the sternocleidomastoid attaching to the manubrium of the sternum and the clavicle. Our patients are breathing with these muscles. That's not a good way to breathe. We can help them to breathe more effectively, but they do breathe this way. The pectoralis muscles. Many of our patients are breathing primarily with the pectoralis muscles. They do that by leaning on something A bedside table comes to mind, or something in their home, the bed rail of the bed at the hospital, and they use these muscles to breathe. It's exhausting to breathe in that way, but it's what they have. Here's a patient who's leaning forward on the arms of a wheelchair, and I would venture that you've seen that, or certainly will see that during your career. Breathing with shoulder muscles, breathing with chest muscles. Here's the point: using a lot more energy and a lot more oxygen to breathe in this inefficient way. Here are the trapezius muscles in the back and neck. These are the traps. Weightlifters love to build their traps. They want to get that V shape that looks so athletic. And I remember doing that myself in younger years. But the patient is breathing with those muscles, and they're not very good breathing muscles. They're much better weightlifting muscles. And then here we go, the trapezius muscle, typified by shrugging the shoulders. If you see the patient breathing and their shoulders are shrugging up and down, they're breathing with accessory muscles. We have the abdominal muscles of expiration, the rectus abdominis, obliques, and transverse abdominis. These muscles are great for blowing out the candles on a birthday cake. They're great for that, but you shouldn't have to breathe with them on a daily basis. So when you see the patient actually working with the abdominal muscles to breathe, then they are in distress, which is what this whole presentation is about, recognizing distress. If they're using their belly muscles, not their diaphragm, but their abdominal muscles to breathe, that's not very good. Pursed lip breathing is one of my favorite topics. I love to address this with every patient. What I'll ask them is I will say, I see that you're breathing with pursed lips. Who taught you to do that? Some of them will say, a respiratory therapist taught me, I went to pulmonary rehab, maybe the lung doctor taught me, but that's actually pretty unusual because the lung doctor doesn't have time to do that. But many, many patients will say, I don't know what you mean. So what that tells me is that they learned themselves to breathe through pursed lips because it helps. What it does is it keeps the airways open a bit longer and allows them to exhale more fully so they can breathe in more fully for the next breath. Fascinated with pursed lip breathing. We also see intercostal retractions. These are the muscles between the ribs, and they pull in those directions that are shown by the arrows to help the patient breathe. All of us, by the way, use these muscles if we exert. If you will look at an Olympic sprinter, for example, what's a really tough race? Let's call the 400-meter sprint, or even the 200-meter sprint. At the end of that race, the runner is using all of these accessory muscles, but our patients use them all the time, or even with any tiny bit of exertion. So that's a very difficult thing and not good for the patient. Let's see here, nasal flaring, particularly in infants. We see the nostrils flare. Again, you'll see this in an athlete who's just finished the race of a lifetime, but you'll see this in infants who are having difficulty breathing. When the nostrils open, they flare with each breath. That is a sign of distress. Pleuritic chest pain, sudden sharp stabbing pain. It's the chest wall. This is not similar to cardiac pain. Cardiac pain is dull, it's central. The patient usually describes it as pressure. This is a sudden stabbing pain, and that's because the pleura are rubbing against each other. They're inflamed and not sliding smoothly. They're just rubbing against each other. It hurts. We have an expression here in Oklahoma. I love the expression. Even the cowboy comes with pleurisy. Even the cowboy comes to us with pleurisy because they simply cannot breathe. Pleuritic chest pain can be associated with any of these things. I don't need to read you the list there. But anything that inflames the pleura can cause that kind of pain. It really hurts. Non-pleuritic pain is important to separate, because if the patient's having a heart attack, we need to know that. That would be myocardial ischemia, pericardial inflammation, pulmonary hypertension, esophagitis sometimes can mimic pleural pain, and local trauma or inflammation. Oh, you've probably heard of costochondritis. Costochondritis is inflammation of the cartilage connecting the ribs to the sternum, and it's a quite different pain. Here are the abnormal chest shapes: kyphosis, the hunchback appearance; scoliosis, the curved spine; hyposcoliosis, the combination of the two, and that's where breathing difficulties come in. Kyphosis alone, scoliosis alone, not much respiratory impact, but together they do. They produce a restrictive defect. Pectus carinatum. This is the pigeon breast where the sternum sticks out in front. Pectus excavatum, the funnel-shaped depression called a funnel chest. And then barrel chest, of course, as we see in our emphysema patients. I'm almost out of time, but I'm aware of that, and we will complete. This shows you what happens with the development of the barrel chest. And normally the AP diameter is about half the lateral diameter, but you notice that it becomes much closer to the lateral diameter, nearer to 1-to-1, and that is the barrel-chested appearance of emphysema, in particular emphysema. Extremity findings are interesting, the skin color, but you can't rely on cyanosis. By the time the patient is blue, they're in really serious condition and may not survive. So we have to be smarter to look for earlier findings. Clubbing of the fingernails. This is the ET call home configuration of the nails. The peripheral edema, distended neck veins, all important findings. Let's see, is this the 60 gets you 90? It is. I'm so glad this is included. I'd forgotten this is here. But a PO2 of about 60 gets you a saturation level of about 90. 60 gets you 90. Put that expression in your head because you may be asked to consider where the saturation should be for a particular PO2 level. Here's the clubbing. I love it. We have a great picture of clubbing here, and this is the cause of this is low blood oxygen for a prolonged period of time that causes tissue under the nail to be hooved up. That's the expression we use here in Oklahoma, hooved up, and creating that ET appearance. Clubbing is a sign of long-term low oxygen. This is, of course, pitting edema. Look at all the fluid accumulating in this patient's ankles. This is congestive heart failure, perhaps even worse than that. Here are the distended neck veins that I've mentioned several times now. They increase during expiration. And now sputum, I think, is our last topic. Yeah, this is the last topic, which is the sputum production. Nothing of particular interest there. The goblet cells produce mucus. The cilia, as you learned in your very first course, should beat back and forth to move the mucus up the airway. One thing we know for sure that decreases the ciliary function is smoking. Cigarette smoking puts the cilia to sleep. Overnight, the cilia start to wake up and they move mucus up, creating the smoker's cough. The smoker's cough that happens first thing in the morning. Let's see, abnormal sputum production. Oh my gosh, there is the green sputum, which is classic of chronic bronchitis, or perhaps of bronchiectasis as well. Also cystic fibrosis for that matter. And here are the colors of sputum and what they mean. Old blood is brown or dark. Active bleeding is bright red. Translucent is actually normal. Copious means just a large amount. Frank hemoptysis is a massive amount of blood that is usually lung cancer. That is often what brings the patient to us with lung cancer. Green is stagnant sputum, which is long-standing. Green and foul-smelling is usually Pseudomonas. Mucoid sputum is asthma, chronic bronchitis. Pink, frothy, This has been on the TMC exam this very week. A student mentioned it to me. Pulmonary edema is pink frothy. Tenacious, very thick secretions, hard to move. Viscous just means thick. Glutinous, yellow or opaque is bacterial infection. Almost done. Cough. Common factors that stimulate the irritant receptors: inflammation, infection, excessive secretions, noxious gases, very hot or cold air, a mass of any sort that's compressing the lungs, and mechanical stimulation like suctioning. By the way, there's no longer any scheduled suctioning on the TMC exam. We only suction when we hear or feel secretions that need to be removed. Non-productive cough. Well, coronavirus, is today's common cause of non-productive cough. The patient just coughs and coughs and coughs, and they never bring anything up. That's because it's viral inflammation and there's nothing to bring up. Inflammation of the airways, mucus accumulation, tumors, and irritation of the pleura. All these are common causes of cough. Productive cough is also interesting. And here we're interested, is it a strong or weak cough? We're interested in the frequency, the pitch, the loudness, and evaluating for the amount, odor, and color of sputum. So, colleagues, that is concluding our assessment presentation. If you know all of that, you will pass the assessment portion of the TMC exam with flying colors. I know it's a lot. I'll be happy to share this with you. I hope you listen to the recording again. And with that, I think I'm done.
Well, Daryl, thank you very much. The breadth of information you have here is just so valuable for students taking the exam and learning these assessment skills so importantly. So as a friendly reminder, next meeting will be the same cadence, the second Wednesday of the month. And next meeting, we will be talking more to career paths. So we'll have different types of careers for respiratory therapists, more than maybe you would imagine available. The world of respiratory therapy is definitely expanding these days into case management and other areas. So we will cover that next time, and look for that in your email, that reminder of the meeting. So thanks again to Daryl for this valuable content, Daniel for the announcement, and we will look forward to seeing you next month. Thanks, everybody. Take care.
Thank you.